Good evening. I want to welcome everybody to this week's Sagis Happy Hour session. Our host this evening is our own Dr. Danielle Wehle. Dr. Wehle did an AP-CP residency at Johns Hopkins University, after which time she did fellowship training at the Ackerman Institute in New York in dermatopathology. She's been practicing as a dermatopathologist for close to 15 years now, very experienced and excellent teacher. And she will be discussing a series of challenging cases underscoring the importance of clinical pathologic correlation in dermatopathology. As always, if you have any questions, please feel free to submit them to education@sagisdx.com, and one of us will get back in touch with you. Hope you enjoy this evening's session, and with that, I'll go ahead and turn it over to Danielle. Danielle?
Thank you, Dr. Davis. I'm happy to have the opportunity to share some very interesting cases with you. And some of these cases would seem banal from the clinical histories that they were submitted with, such as nevus, cyst, squamous cell carcinoma, and a neoplasm of uncertain behavior. But as you'll see, on our first case, it's quite interesting. It comes from the back of a 60-year-old man, and it came with the clinical history of nevus. So here we have this dermal-based proliferation that's quite cellular, and it was MART1 positive, confirming that it was in fact a melanocytic proliferation in the dermis, and here's the epidermis for reference. On closer inspection, we can see that these cells are somewhat spindled and they infiltrate the pink dermal collagen in an atypical fashion with enlarged hyperchromatic or darkly staining nuclei. And this was called by me an atypical intradermal melanocytic proliferation, and I recommended removing the remainder for further evaluation. And on the excision, we see that the lesion is deceptively much larger than the shave biopsy would indicate. So here is the epidermis and hair follicles for reference. And you can see that this lesion in this fairly large excision extends all the way into the deep reticular dermis. And these are adipose cells in the superficial subcutis. So it's a quite deep cellular proliferation. And we see this a lot where the surface of a lesion will be somewhat narrow and the base of the lesion is quite a bit wider than the surface would indicate. And I like to call these iceberg lesions. And over the years, I've seen a number of very ominous lesions present in this way, such as nodular melanomas, metastatic lesions, and sarcomas. So palpation and getting a representative sample is key to making the diagnosis at times. And so here on closer inspection of our current excision, so this proliferation you can see is quite broad and densely cellular. The cellular infiltrate consists predominantly of these spindled cells that are associated with melanin pigment, which you can see in several of the foci here. And additionally, we have some cytologic atypia. So these nuclei are quite large. They have cherry red nucleoli, and this is a very mitotically active proliferation. We shouldn't be seeing mitoses deep in the dermis on a banal intradermal melanocytic proliferation. And confirming that it is melanocytic is our SOX10 immunostain. But here we have another very helpful immunostain, BAP1, in these types of proliferations. So this lesion was negative for BAP1. And on follow-up with the clinician, because of that negative BAP1, it calls up a differential diagnostic possibility of uveal melanoma or a primary blue nevus-like melanoma. And in following up with the clinician, the patient did in fact have a history of uveal melanoma. So this lesion is consistent with a metastasis from the patient's prior uveal melanoma. And however, we cannot entirely exclude the less likely possibility of a primary blue nevus-like melanoma on the back. And so-called blue proliferations in general, most commonly blue nevi are what we see. What are these benign dermal proliferations that have spindled cells that contain cytoplasmic melanin? And that cytoplasmic melanin deep in the dermis gives them a blue appearance due to the Tyndall effect, in which the melanin absorbs longer wavelengths of light and reflects the shorter blue wavelengths, giving them their appearance. Commonly, what we see are superficial blue nevi as well as some cellular blue nevi, which our current case somewhat mimicked in that it was also a nodular and deep proliferation of spindled cells. And blue proliferations in general are genetically distinct in that they have GNAC and GNA11 mutations, as opposed to their epidermal counterparts, common nevi and melanomas, which have BRAF, NRAS, and c-KIT mutations. However, blue nevus-like melanoma and uveal melanomas, which share overlapping histologic features with cellular blue nevi, but in addition to having broad, deep proliferation of spindled cells and a broad base with some associated melanin pigment. Additionally, they will display cytologic atypia, as our case did, and mitotic activity beyond that which is acceptable in a common blue nevus or a cellular blue nevus. And their genetic mutations will include not only GNAC and GNA11, but additionally they can have BAP1 mutations, which will lead to a negative BAP1 immunohistochemical stain, as was present in this case. Uveal melanomas in general have mutually exclusive either BAP1 mutations, which portend a poor prognosis, or poorer than those who have EIF1AX or SF3B1 mutations, which are more favorable prognostically. Additionally, blue nevus-like melanomas are also highly aggressive and often lethal, with metastasis not only to other skin locations, as in this case, but to lymph nodes and lung. BAP-IHC, as a result, is very helpful in distinguishing cellular blue nevi from these more ominous proliferations. And BAP1 is a bio-associated protein which is coded for on chromosome 3 and aids in DNA repair and gene transcription. When it's mutated, it can lead to BAP tumor predisposition syndrome, which confers an increased frequency of atypical melanocytic nevi, melanomas, basal cell carcinomas, as well as other types of carcinomas such as breast, ovarian, pancreatic carcinomas, and mesothelioma. Additionally, patients can develop uveal melanomas and blue nevus-like melanomas. Our next case was seen on the cheek of a 50-year-old female and came with another banal-sounding history of rule-out cyst. And Over the years, I've collected a number of cases that came masquerading as cysts, such as nodular melanomas, sarcomas, cystic primary carcinomas, and recently I've seen a metastatic renal cell carcinoma that was thought to be a cyst clinically. So the moral is, if something looks clinically like a cyst, be sure to palpate the lesion and get representative sampling. And here we have a very nice excisional biopsy of the current lesion. Here's the epidermis for reference, and you can see it is a cystic lesion. However, even on low power, we can appreciate that the lining of this cystic lesion is quite thick, definitely thicker and more complex than your average epidermal cyst. And on closer inspection, we can see what we call cribiforming, in that you have piling up of these cuboidal cells in some areas surrounding these punched out Swiss cheese-like holes. That's known as cribiforming, and that's typically not a good sign in various body locations. And here you can see what would be a more usual cyst lining of a thin single cell lining, as opposed to just adjacent to it, where the tumor actually shows quite haphazard arrangement of the cells, with nuclei somewhat overlapping and forming these punched out cribiforming pattern spaces. So at this location, these histologic features should call up a certain differential diagnosis, which would lead us to do some neuroendocrine markers such as synaptophysin. And this tumor shows brown precipitate in the tumor, which indicates that it's positive for synaptophysin immunohistochemical marker. These overall features are classic for endocrine mucin producing carcinoma. This is a low-grade sweat gland carcinoma with a predilection for the periorbital region of women. And the histology, as we saw here, shows epithelial proliferation with small cystic spaces, and mucin is produced around the small spaces. Additionally, it will stain positively with immunohistochemical markers that are neuroendocrine markers, such as synaptophysin. And it's important to know the differential diagnosis for these histologic features at this location, and to do the proper immunostains, because as you can see here, we have two different lesions. One is an endocrine mucin producing carcinoma of the eyelid, and it has quite a similar histologic pattern to a banal primary adnexal carcinoma known as a hydradenoма, which can also occur on the head and neck and near the eyelid. So knowing the differential and doing the proper immunostains is critical for this diagnosis. Our next case, also very interesting, on the wrist of a 71-year-old man. And so this was a low power view of this lesion, which is quite a dense proliferation of blood vessels. On closer inspection of this lesion, we can see that in areas, the cells associated with these abortive vascular structures are somewhat spindled, and they form these pseudovascular spaces that contain erythrocytes. And so this histology is classic for a certain type of entity, which would lead us to do an HHV8 immunostain. And this lesion showed positive nuclear staining for HHV8. So these features are classic for nodular endemic Kaposi sarcoma. So in discussing this case with the clinician, I learned that there was no history of immunosuppression in this patient. And so this is classic for endemic Kaposis. And it usually is seen in elderly gentlemen on the distal extremities, as in this case. Mediterranean and Jewish populations have an increased frequency of these types of lesions, and predisposition to tumor induction is conferred by HHV8. And the lesion will have a long and indolent course. It's rarely fatal. Other types of Kaposis are, as we said, immunosuppression related and AIDS related. And the histology may present as a patch or a plaque, and as in this case, a nodule of spindled cells that contain pseudovascular spaces with erythrocytes. And the nuclear HHV8 immunostain is very helpful in that it is both sensitive and specific, more so than many of the immunostains that we use commonly for Kaposis. And our next lesion was seen on the face of a 56-year-old gentleman and thought clinically to be a squamous cell carcinoma. And we see this shaved biopsy of the lesion yielded a densely cellular proliferation of these blue cells. And on closer inspection, we can see that these bluish cells are lymphocytes and plasma cells, and they're associated with these other monocytes that have more clear cytoplasm. And those cells are histiocytes. And here we have collections of neutrophils as well. And the histiocytes have organisms in their cytoplasm. And if we were to look at those organisms on a 100x oil immersion lens, we would see that they have this appearance. So they have this ovoid nucleus and a kinetoplast, which is classic for this lesion, which is leishmaniasis. And it's important not only to identify the organisms histologically, but also PCR speciation of the organism is incredibly helpful for management of the patients. So these lesions, as you may know, are typically seen in tropical locations, often in South America and Central America. But when seen in the United States, there are two types that are most commonly seen in states that are in the southern region, such as in Texas. And those types are L. mexicana and L. braziliensis. And it's important to speciate and know which type you're dealing with, because mexicana typically produces a localized, non-aggressive cutaneous infection, whereas braziliensis is often recurrent, more difficult to treat, and can cause mucosal infections in addition to these localized cutaneous lesions. Thank you for your attention and for allowing me to share these interesting cases. Have a good evening.